Hello friends, today we are going to discuss about torsion testis. Coming to definition, torsion testis is nothing but twisting of spermatic cord and its contents. Twisting of spermatic cord and its contents. So we all know what does spermatic cord contain. Spermatic cord contains testicular artery, vas deferens and tympaniform plexus of veins. So when there is twisting of spermatic cord, blood supply to testis gets compromised, which is why it leads to testicular necrosis. So twisting of spermatic cord and its contents lead to compromised blood supply to testis. So what will happen if there is a decreased blood supply to testis? So testis will die. That leads to testicular necrosis. And what can we do? By early surgery, we can save the testis. That is emergency orchidopexy. Within 6 hours, testis is 100% salvageable. A brief discussion about spermatic cord. So if you take this is if this is abdomen and this is inguinal area, from superficial inguinal ring to scrotum, the spermatic cord will come from superficial deep ring to superficial ring, and from superficial ring it will reach to scrotum and supply testis. So what does spermatic cord contain? This is an image showing spermatic cord. Torsion. There are two types of torsion: extravaginal torsion intravaginal torsion. What is extravaginal torsion? Extravaginal torsion, this is exclusively seen in neonates, whereas intravaginal torsion is seen in adolescent males. This is exclusive for neonates, whereas intravaginal torsion is seen in adolescent males. What exactly is extravaginal torsion? In neonates, the scrotum is not yet attached to scrotum, so there is no fixity of testis to scrotum, so testis can get twisted. So this is called extravaginal torsion. In extravaginal torsion, both spermatic cord and tunica vaginalis gets twisted as a single unit. Here spermatic cord and tunica vaginalis gets twisted as single unit. Let's see images of intravaginal and extravaginal torsion. See, this is an image of intravaginal torsion and this is an image of extravaginal torsion. If you look at the image carefully, this blue thing, bluish green thing is tunica vaginalis, and this is spermatic cord. in intravaginal torsion, the spermatic cord is getting twisted, and it is twisted within the tunica vaginalis. So here in intravaginal torsion, the tunica vaginalis is not involved, whereas you can see in extravaginal torsion that both spermatic cord and tunica vaginalis is getting twisted. So this intravaginal torsion is seen in adults and males, and extravaginal torsion is exclusive in neonates. This is for neonates, and this is for adults and males. So till now, what do we know about intravaginal torsion? One, this is seen in adults and males. Number two, here only the spermatic cord is getting twisted. Okay, so now we can see what are the risk factors causing intravaginal torsion. So the most common risk factor which leads to intravaginal torsion is bell clapper deformity. What is bell clapper deformity? So if you see, this is the cord and this is epididymis, and this is testis, epididymis and spermatic cord, and if you think the blue one around it will be tunica vaginalis. This is tunica vaginalis. So this is normal testis, in which we have epididymis or posterior aspect and the tunica vaginalis covering over it. This is how normal testis looks like. But in bell clapper deformity, we have high investment of tunica vaginalis. That means tunica vaginalis gets attached at a higher position on spermatic cord, so that the testis is dangling now free within the tunica vaginalis. So this is the spermatic cord. So this is the epididymis. This is the testis. Instead of attaching as in the normal position, the tunica vaginalis gets attached to a higher position. This is called high investment of tunica vaginalis. Because of the high investment of tunica vaginalis, now this testis is hanging within the tunica vaginalis like a clapper in bell. Have you seen this? If this is bell, we all see there is a clapper in the bell. So now this is a simple illustration of bell. So this is the bell. This is the clapper within the bell. Now, because of high investment of tunica vaginalis, now our testis is hanging like a clapper in the bell. So this is called bell clapper deformity. This is the most this is the most common cause of intravaginal torsion in adults and males. Okay, and bell clapper deformity is mostly bilateral. Okay, so what are the other risk factors? Let's know about the clinical presentation of the patient. We divide them into two types by symptoms. Patient comes to us with symptoms. We examine the patient and we'll get signs in local examination. Okay. Patient comes with the severe pain in groin region. Okay, there will be severe pain in groin unilaterally, that is most on the affected side. Okay, sometimes the pain may also get radiated to lower abdomen. So mostly the patient will come to you with pain in groin region, and there will be no history of trauma. Okay, and because of this severe pain, patient may get nausea. Sometimes he may also vomit. Actually, if you ask about the history, most of them might be doing any violent physical activity, lifting weights, like violent physical activity like lifting weights, sexual intercourse, or playing a vigorous game. Because of that, when the abdominal muscles contract, the cremastric muscle, which is an extension of abdominal muscles, it will also contract briskly. So there will be brisk cremastric reflex. Okay. So because of the violent physical activity, abdominal muscles contract violently, and cremastric also will contract very strongly. So there will be brisk cremastric reflex, and since cremaster is attached more or less spirally, in the presence of risk factors like bell clapper deformity, it will lead to torsion of testis in vertical axis. Okay, so now what are the signs? So first, for inspection, what do we see when we examine the patient of torsion testis? The affected side scrotum will be swollen, red, and edematous. Okay, what do we know on palpation? One, the affected testis will be lying high up in the scrotum. Okay, and we can palpate a twisted cord around it. Affected testis will be high, cord is palpable above it, twisted cord. It will be extremely tender to touch. How do we diagnose this condition? Diagnosis is mainly clinical, and management will be based on clinical examination, but investigation of choice would be color Doppler. Management: in torsion testis, we need to do scrotal exploration. See, diagnosis is mainly clinical, but best investigation to do in such situations is Doppler ultrasound. But if Doppler is not available, we should not wait the patient. We should not delay the surgical exploration, because you can take the consent from parents or from the child if he is major, and we need to proceed with scrotal exploration, because time is very important in such situations. So you should not wait for Doppler, and you can go ahead with clinical suspicion and scrotal exploration. Emergency orchidopexy, if performed within 6 hours, can save the testis 100%. So management of testicular torsion is scrotal exploration. How do you do it? By giving a paramedian incision, we'll explore the testis. So on looking at the testis, if testis is viable, we can detort the testis, that is untwisting of spermatic cord. We can untwist that spermatic cord, and we can prevent retorsion by orchidopexy, by taking 3 suture bites with non-observable suture between tunica albuginea and dartos muscle, or tunica albuginea and scrotal raphe. Okay, here we are untwisting the cord and we are preventing it retorsion by just fixation to surrounding structure. Okay, and you need to explore the contralateral testis also, contralateral scrotal exploration too. Because Bell Clapper testis is bilateral condition. So you need to do